Hi everyone, Dr. Demito here. I put together a few slides to help guide you as you work towards the development of your differential diagnosis. I have a larger scale presentation that I include in a monthly workshop, but I took some of the slides from that presentation and put this one together to hopefully give some of you direction in the development of your assignments. So let's start with what is a differential diagnosis? Well, essentially, what you're doing is compiling a list of the what ifs. So I have a patient that comes in presents with a specific amount of symptoms, and I take all those clues that the patient has given me, and then through my physical examination and any lab tests that are done, I develop a list of the potential diagnoses that it can be. And usually they're prioritized by likelihood and urgencies. And we do this not only to help us in our critical thinking process, but we also do it to protect us from a legal standpoint. Many courts view the formulation and documentation of differential diagnosis as evidence of the provider's competence, prudence, and thoughtfulness. So, um, the development of a differential diagnosis is just not something that we're requiring you to do at this point as a student. This is something that, for those of you who are going on to the FNP program, the development of differential diagnosis is something you will carry through with you throughout the program and then in practice. So healthcare providers, be it physicians, um, nurse practitioners, or physician assistants, develop differential diagnosis in their documentation. The challenge is identifying what the differential diagnosis is. And in doing so, we recognize a collection of signs and symptoms. We take the information that we have learned through advanced training, such as pathophysiology. We restate in terms of disease. So one of the reasons that advanced pathophysiology is such an important course for you all is because you're going to take those key components, just as I mentioned in our first four review. So we have to identify how the body processes occur in order to identify what the illness could be, and then how to define the treatment we're going to prescribe for that complaint. We want to restate the terms in disease, reconnect with the initial complaint, and then reframe, reconsider the diagnosis when there's a progression of an unusual natural history. So what does that mean? In practice, I usually will have 3 to 5 differential diagnoses for my patients. And I'll tell my patients, especially when I'm dealing with dermatologic issues, because many dermatologic issues have uh, not etiology, but they have similar presentation. So I will tell my patients that through the clues that I have obtained through the patient history, which is so incredibly important, through the examination, and through the experience that I have and the knowledge base I have, these are the 3 most likely diagnoses for what you have. So I'm going to prescribe this treatment. Now, if this treatment doesn't see any improvement in 3 to 5 days, I need you to come back, because then we're going to have to reevaluate the symptoms and then re-identify what potential diagnoses it could be. So often when providers are trying to identify what the differential diagnosis is, they may struggle by trying to fit that data into their diagnosis hole. So that's what this little picture illustrates. You don't want to try and fit a square peg into a round hole. If it doesn't fit, it doesn't fit. Then you need to go back to the data and go through once again, the history. So when you are performing the patient history, or for our purposes, watching the Real DX videos, think to yourself, if you were the provider there, what other questions would you ask that patient? And you may need to revisit that. So once the history is taken, if during the examination I uncover something, I may say, hey, at have you been camping? Have you been out of the country? Things that I don't think of during the initial uh, history. And they may say, oh my gosh, yes, I forgot to tell you. And then all of a sudden that peg starts to fit into that round hole. So um, always try to think of whatever it could be. Don't be afraid to think outside the box. Now, when you've eliminated the impossible, whatever remains, however improbable, must be the truth. So, if I have a patient that presents with symptoms and I can't find any corroborating instance as to why they would have this symptom, but everything else leads up to it, it must be it. Now, let's talk about a case. So we have a case. We've got an obese Caucasian male with a history of hypertension and smoking, complains of severe lower back pain that lasted 4 days. The pain's accompanied by occasional vomiting and radiates intermittently to both lower quadrants of the abdomen. The increased severity of back pain had awoken him on the morning that he sees his provider. Vital signs are normal except for a mild elevation of the systolic blood pressure. The nurse practitioner assesses the patient and finds no significant physical abnormalities. Femoral pulses are strong and symmetrical. A flat plate x-ray of the abdomen is read and is later confirmed as normal. A complete blood count is normal. So now let's see, what could it be? How do I decide what it could be? Now, first of all, you are bringing a wealth of knowledge to the table with the information you've gathered over your years of practicing at the bedside. I have to say, when I talk to those at certifying bodies like AANP and ANCC, who are the certification providers for advanced practice nurses, I have asked this question and they say, number one, the greatest success that students will find in test taking and functioning as nurse practitioners is the time they have spent at the bedside. So that time you have spent at the bedside is going to be a great advantage for you in your assessment skills, also your knowledge base of the different types of syndromes, illnesses that you have been exposed to. Use resources. The Benner Library offers up-to-date, and this link will take you there where you can sign up for it. It's free, and it is provided to all ONU advanced practice students. You can download an app called Medline, and it is free. I used to use this all the time in practice. Epocrates has a free version and a paid version. And I like Epocrates. You'll find that there are advantages and disadvantages to every program that you look at. So now let's look at this patient. Let's think. Just thinking off the top of my head, I would think, maybe it's musculoskeletal strain, pancreatitis, kidney stone. All those things come to my mind when I think about the symptoms that the patient's experiencing. Now the outcome. 2 days later, the patient is found dead at home. An autopsy revealed a ruptured abdominal aortic aneurysm, or a AAA, with 3,000 cc's of blood in the retroperitoneal space. The patient's family threatens legal action against the nurse practitioner for alleging failure to diagnose the condition and failure to provide adequate discharge instructions. So this is one of the reasons that differential diagnoses and patient education is so incredibly important for not only physicians, but for advanced practice registered nurses as well. And any case that I present to you, these are real cases that I get off of malpractice insurance websites. Many of them, like NSO, have examples of cases against nurse practitioners. Now, what can we learn from this case? That a leaking AAA can mimic renal colic and mechanical back pain, diverticulitis, gastroenteritis. A AAA might be considered in the differential diagnosis in an older patient with symptoms suggestive of renal colic. So this is something you'd want to consider. I've just learned something now. When I have an elderly patient with symptoms of renal colic, I'm definitely going to add a AAA in my differential diagnosis. A patient with persistent symptoms may warrant a new evaluation as appropriate, and an alternative diagnosis, including the worst case possible, should be considered. So, that being said, as a practicing provider, I always think of my patients in the worst case scenario. So, a patient presents into my office, they have a stiff neck, a fever, and a headache. Number one on my list is bacterial meningitis. So, until I can eliminate that, I'm going for the worst case scenario. Patient presents with difficult swallowing, a severe sore throat, scale 9 out of 10 on a pain scale. They have a peritonsillar abscess until I can prove otherwise. So always consider a worst case scenario when you are considering your differential diagnoses. Another lesson that can be learned, patients that require analgesia, we need to be of understanding that it may mask symptoms. So the analgesia that was provided to this patient, which I'm not sure if I mentioned that or not, but that actually may have masked some of the pain. So if the pain had not been masked, perhaps the patient would have returned for reevaluation. Inappropriate clinical circumstances, the medical record should indicate that the diagnosis was the worst prognosis. In this case, AAA was considered and was pursued. The rationale for not investigating should also be clearly documented. So, for example, I know according to the American Academy of Pediatrics that children under the age of 18 who test negative for a rapid strep test in the office should have a throat culture sent to confirm that negative diagnosis. Now, sometimes parents refuse to have it done because they may not have insurance, and that test costs $113 from the lab. I always put in my documentation for those parents risks and patient denies need for throat culture, risks and benefit or risks of not obtaining a throat culture discussed with the patient. Patient continues to deny or parent continues to deny need for throat culture. So that way I have all my bases covered. So if in the effect this kid does have strep and it goes undiagnosed and they end up with heart condition or kidney condition, I have it documented that I wanted to do that throat culture, but the parent didn't want it sent. Look for red flags. Findings can prompt experienced physicians, nurse practitioners, physician assistants to accept or rule in a series specific diagnosis. Yet, even experienced physicians are often surprised by the range of symptoms and signs of disease. And I know I have patients, I always do a pretty thorough physical on my patients. I always check eyes, ears, nose, throat, heart, lungs. Pretty much regardless of their diagnosis. And I get patients that often say to me, my gosh, when I go to my doctor for a check, um, they don't ever even touch me, or they spend 2 seconds listening to my lungs. So I'm doing that because I want to ensure I'm covering all the bases, not just to protect myself legally, but I have a duty to my patient to ensure that I am providing them complete and thorough examination. History taking. So I wanted to just talk a little bit about the importance of history taking, and I understand with the real DX, you don't have the ability to take the history, but I want you to begin thinking about it because this is something that peer experts will consider in a legal case, Has the provider taken an adequate history? Do you know the patient's health conditions? If the patient is unable to provide a history, have you consulted with others to help? So, language lines. Also, if the patient is mentally incapacitated, um, is the guardian that they're with a good um, historian? Have you adequately assessed any relevant risk factors like family history? Are there any red flag symptoms? Have you determined what the patient's already done to manage his or her own symptoms? That goes back to old carts in your HPI. If assessing a patient over the telephone, have you obtained sufficient history to be able to provide professional opinion? I'm not a big fan of telephone triaging, so because it doesn't present a full picture. Have you read the notes taken by other healthcare professionals? And I do this fortunately now with the manner in which our electronic medical record systems communicate with each other. I can often go back and look to see what this patient has been treated for, anything that they may have forgotten in the background. Many patients don't have a clue what, I know I take a blood pressure medicine, but they don't know what the name of it is. Or you may note that they're on a blood pressure medicine, but they didn't make comment that they had hypertension. And they'll say, oh, well, I don't have it anymore. I take a pill that made it go away. If you also are pertinent medical records, test results, and consultant reports available, and have they been reviewed? In a legal action, peer experts are going to be critical if they consider the physical examination to have been cursory, so given the patient's symptoms. So that's why I'm very strict about ensuring that anything that's mentioned in the CC or the HPI has to be evaluated in the review of systems. Any body system that is mentioned in the CC, HPI, review of systems has to be examined. So if you have a patient and they present one of their symptoms that they're presenting with is a headache, you have to check their neurologic status. Failure to do so deems that you are not providing a complete physical examination. Um, it's always necessary to take vital signs. And have you assessed the patient appropriately for the clinical complaint? It makes me crazy when people come in presenting with symptoms of a cough and the provider wants to listen to their lungs over their clothes. You cannot listen to those lung sounds well and appropriately over clothing. Also, you must listen to all fields. You must advise the patient to take deep breath in and out through the mouth. When you're listening to the front, take a deep breath in, blow it out forcefully and hard. Failure to do so provides a gap to miss a potential pneumonia. Also, if to avoid misunderstandings, if you are doing any examinations of the genitalia, you need to have a chaperone present. Now, differential diagnosis is the development of a list of possible conditions that might produce the patient's symptoms. And it's an important part of critical reasoning. So if a serious diagnosis comes to mind based on the patient's symptoms, have you considered the likelihood of it and whether it needs to be ruled out by testing or referral? So you know when you're doing those cases, it'll ask you appropriate referrals. So if you have a patient that is presenting with a severe hyperthyroidism, those patients need to go to an endocrinologist. But in your note, you need to clearly establish why you are referring them to the endocrinologist. Have you considered ruling out the worst case scenario? Have you discussed possible diagnoses with your supervisor or collaborating physician? I just had a case the other day where I had a patient who I don't contact my collaborating physician often. In 3 years I've called her. Now this is the third time. And she's wonderful, wonderful, wonderful. I had a patient who had presented with sinusitis and allergic to various antibiotics. But the problem was she had had her colon removed for ulcerative colitis, and I'm like, oh, I don't know what to give her. And she had had C. diff in the past. So I was perplexed on that. And I knew what my gut was telling me to do. In fact, part of my gut was saying, I don't think that she should be seen here. But she couldn't get in with a regular physician. So I called my collaborating physician, and she and I discussed it, and we came up with a treatment plan for her. Formulating a diagnosis. Don't rely on the classic features of a disease. It can be misleading. Sometimes you just think, oh my gosh, I've seen this so many times. This is it. This is it. You have to keep an open mind. You have to have a sufficient understanding of the clinical presentation in order to provide a diagnosis. What could it be? If the patient returns with persistent symptoms or fails to respond to therapy, you need to start over again completely. Have you considered using diagnostic decision support trees? They can be part of an electronic health medical record, or if you go to different sites like the Infectious Disease Society of America, they have an algorithm that you can look for that will help you identify whether or not you should treat a sinusitis or whether or not you should treat a bronchitis. So if for those of you who are planning on moving forward to the FNP track, you have to become comfortable with using the internet to look to see what the current clinical guidelines are. It is so incredibly important. Are you distressed by the patient's condition or behavior? Allowing yourself to become anxious by a particular case can cloud your judgment and inhibit an accurate diagnosis. So I'll admit, when I had that patient come in that had no colon, I was a little anxious about it because I didn't want to make the wrong decision. So I kind of had to take a deep breath and relax and think about it with a clear head. Order investigations. So when you're deciding whether to use available diagnostic testing, you want to know if they're in the patient's best interests. Are you familiar with the current clinical practice guidelines? Have you requested the appropriate investigation? Does your completed diagnostic imaging requisition contain pertinent clinical information to help the radiologist? So, if I am ordering a chest x-ray because I hear fluid in the lower left lobe, I'm going to put that on the order. Uh, Hear fluid in the lower left lobe, so that when the radiologist is reviewing those screens, they've kind of got a little clue themselves that they're going to zero in and see, because that's where I'm concerned. Um, does your completed requisition contain the pertinent clinical specimen information? Okay, so, and you don't want that's lab ordering and making sure they're labeled appropriately. And yes, even as nurse practitioners, sometimes I do not have a medical assistant, so I am um, getting my specimens and I am labeling them myself. So you want to make sure. It's much better now with the way the electronic medical record system is done, and our labels print out automatically, but sometimes those systems go down and you have to go back to handwriting it. Is it possible the patient's pregnant? Oh, I always check that. If patients come in presenting with urinary tract infection symptoms, if they're in the childbearing age, I always do a urine pregnancy test on them just to rule that out. Because if you're pregnant, I'm not going to treat you with Cipro, Bactrim. I'm going to use Macrobid because it is going to protect you. Now, again, I always am thinking, if the patient doesn't have insurance, am I going to burden them? And they have a good history of periods or on birth control. Am I going to burden that patient by making them pay for that medical test? All of these things, as a healthcare provider, you need to consider. Here's another one for us. Oh, no, we're not going to do that one. Here's the case study we're going to do. A 34-year-old woman presents with recurrent crampy abdominal pain over the last few years. She has a pattern of intermittent constipation and loose stool. She denies blood in the stool. The pain tends to be diffuse in nature and seems unrelated to diet, exercise, and or stress. She's new to your practice, having moved to this region recently. She's because of her husband's job. I want to find out what's wrong. I'm tired of always worrying where a bathroom is. That's her chief complaint. The physical exam revealed an essentially normal abdominal exam and overall negative general exam. The stool was negative for blood and mucus. The patient is of normal height and weight. She doesn't smoke. She only drinks socially, has a good job, denies excess stress, is married without children, and no recent weight loss. Let's think of some questions. What additional data may you need from the patient? Think about it. What, if any, laboratory tests do you need and why? Well, maybe I want a pregnancy test on her, CBC. I might want a transvaginal ultrasound to rule out any gynecological issues. So now, what is your list of working diagnoses and how do you rule them out? I'm thinking of the worst case scenario, colon cancer. But she's negative for blood. IBS, irritable bowel syndrome. She has constipation, diarrhea, cramping. No blood, though. Crohn's disease, no blood. And she has constipation. Ulcerative colitis, no blood. Now, I wrote has mucus, but that was an error. She didn't have mucus. So that's one of the ways that you can help to rule in or rule out diagnoses. What plan of care would you devise for this patient and what follow-up is needed? What patient education is important? What health promotion strategies are important for this patient at this point in time? What complementary therapies may be helpful for the patient? Well, first of all, I want to know what age she is. Does she have any risk factors for colon cancer? Any family members have colon cancer? And I may consider referring to GI. Maybe I want her to have a colonoscopy if she's having issues. That could be some follow-up too. What do we do with people who, now I'm thinking just from looking at the symptoms that this is IBS. What health promotion strategies are important? High fiber diet, drinking lots of fluids, avoiding things like caffeine, keep a food diary. What complementary therapies might be helpful for this patient? Biofeedback, meditation, yoga, exercise, lots of other things that you can consider also. All right. An 18-year-old woman presents with a new onset abdominal pain, nausea, vomiting over the past 18 hours. She's accompanied by her mother. She's tearful and in distress. The patient's not new to your practice. You've been following her for years, and the CC is the pain's getting worse. The physical exam is not abnormal. Some right lower quadrant tenderness with rebound. Denies pregnancy, denies sexual contact. Now let's think about this patient. What other data do you need to diagnose the patient? Would you do a gynae exam and why? What laboratory tests are important and why? Would you do imaging and why? Do you need a surgical consult? How many patients diagnosed with appendicitis is actually have the condition at the time of surgery when the appendix is directly visualized? What are potential complications? And what is the plan of care for this patient? Well, this patient walks in. She has appendicitis until I can rule it out otherwise. That's number one on the top list of my differentials. So if again, a lot of it has to do with your setting. I've had patients come into my acute care clinic with symptoms like this, and I'll send them to the emergency department and let the emergency department follow through with a patient like this. If I'm in the emergency department and they come in, of course I want a CBC, ultrasound, maybe a CAT scan, maybe not a CAT scan. We might be able to diagnose it on ultrasound. And then when those things all come back, let's decide whether or not we need to have a surgical consult. So I just wanted to take a little bit of your time today to hopefully clear up some of the muddling that can occur when you're new to advanced pathophysiology and you're trying to see it from the perspective of a potential or an up-and-coming healthcare provider. So hopefully this will help you a little bit, and good luck as you move forward on your cases.